Hello, my name is Monika Karki, and today I'll be presenting a case of suspected serotonin syndrome due to inappropriate polypharmacy. Our patient is a mid-70s male who carries a diagnosis of chronic kidney disease, hyperlipidemia, major depressive disorder, and generalized anxiety disorder, who presented to the emergency department due to altered mental status as well as fecal and urinary incontinence. The patient's sister was contacted for collateral information, and she revealed that 1 month prior, the patient was found to be living in a state of self neglect and voluntarily admitted himself to a local residential mental health facility for depressive symptoms and suicidal ideation. A review of his medical record revealed a home psychiatric medication regimen of risperidone 5 milligrams once a day, buspirone 15 milligrams 3 times a day, trazodone 50 milligrams at night, venlafaxine 75 milligrams once a day, and bupropion 300 milligrams as an extended release tablet. This regimen was adjusted at the mental health center to discontinue risperidone and add aripiprazole 10 milligrams once a day and increase his venlafaxine to 225 milligrams once a day. Upon admission, the patient did have a rectal temperature of 39.1 degrees Celsius. All other vitals were within normal limits. Physical examination was significant for nonsensical, slow, and slurred speech, and the patient was oriented only to self. Initial lab work was significant for elevated lactic acid and creatinine levels. Other diagnostic studies did not point towards a particular medical diagnosis. The patient was started on empiric IV antibiotics in the ED. He was given a diagnosis of acute toxic metabolic encephalopathy of unclear etiology and admitted to the med-surg floor for further monitoring. His lactic acidosis did resolve, and blood and urine cultures came back negative. However, on day 3, he spiked another fever and was given a second round of antibiotics. At this point, it was suspected that his symptoms might be related to his medications, so on day 4, the decision was made to begin tapering his psychiatric meds, starting with the venlafaxine. On day 10, he had a rectal temperature of 40.9 degrees Celsius, pulse of 101, respiratory rate of 26, and blood pressure of 147/92. He was subsequently transferred to the ICU for a full medical workup to rule out diagnoses such as sepsis. At this point, myoclonus was elicited in his lower extremities, and it was suspected that the patient may be experiencing serotonin syndrome. All psychiatric medications were discontinued, and he was immediately started on cyproheptadine. On day 11, his vitals stabilized, and on day 13, he was transferred to step down after remaining hemodynamically stable. Unfortunately, the patient's condition continued to deteriorate during the course of his hospital stay as he contracted pneumonia as well as other medical complications. On day 29, he was discharged to inpatient hospice care. Now, serotonin syndrome is defined as increased serotonergic activity and has many causes, including overdose of one serotonergic drug, the addition of a new serotonergic drug, or the use of multiple drugs that increase serotonin activity. It can be defined using the Hunter criteria, and as seen in the images, its symptoms include altered mental status, autonomic nervous system overactivity, and neuromuscular hyperactivity. We wanted to present this case not only because of the uncommon nature of the patient's diagnosis, but also because of the many important take-home points. This is the importance of educating all healthcare workers on the pathology, presentation, and management of serotonin syndrome. Research shows that it often goes undetected but can quickly become life-threatening if not addressed, and most physicians will come across patients who are on one or more serotonergic medications. These medications should be thoroughly reviewed with the patient and the prescribing physician when possible to determine each medication's necessity and the appropriate dosing to ensure therapeutic effect without any adverse side effects. In this case, our patient was taking up to 5 medications that affect serotonin levels, and his medication regimen should have been scrutinized more deeply upon hospital admission. Lastly, this case highlights the importance of a multidisciplinary approach for patients that have numerous ongoing health complications during their hospital stay. While serotonin syndrome was suspected to be the cause of this patient's symptoms, many other diagnoses had to be ruled out in the process. This includes underlying infections and other conditions such as neuroleptic malignant syndrome. And that concludes our presentation today.